All right, good morning, everyone. Welcome to the 5th annual BPrep Patient Forum. We're happy to have you with us this morning, and we have a great morning lined up for you. So just a few reminders for everyone. All of our panelists are going to be hidden until it's their time to speak with you. They're on mute. As our attendees, you are all automatically muted as well. But please, if you have questions, please put them into the chat. We will be monitoring the chat throughout the session. And these sessions will be recorded and posted on our website after the event. So we will go ahead and get started. Maybe. All right. So before we jump into BPrep, our high-risk program, I want to tell you a little bit about where BPrep lives. And BPrep lives in the Comprehensive Breast Center at Brigham Women's Hospital. See patients for evaluation of nonspecific breast complaints, non-cancerous complaints. We do workups for abnormal breast imaging. And then, of course, we do evaluation of patients with suspected or known increased risk of breast cancer, or just patients who want to come in and learn more about their breast cancer risk. We're going to talk a lot this morning about what those risk factors are. But the program is housed in the breast center at the Brigham, and really anybody can come to our program either for an evaluation. So this is how it works. Again, anyone can come in. And any reason there at the top of the funnel, you see abnormal imaging, breast complaints, family history, dense breast. Everybody who comes to the program takes a standardized risk assessment. And through that risk assessment is how we evaluate whether patients are at increased risk and are eligible to stay in our high-risk program. Or if patients are not at elevated risk, then that's also reassuring, and those patients can go back and continue their follow-up and their screening with their primary care physicians or their OBGYNs. And really part of our goal is, again, to identify women at elevated risk, to educate them about what they can do, and to learn from each of our patients. So the criteria for ongoing follow-up in our program: patients with the family history of genetic predisposition or suspected to have a genetic predisposition. We work collaboratively with our genetics colleagues from the Dana-Farber. Women who are found to have genetic mutations, we then transfer their follow-up care over into the genetics program. Women who have variants of uncertain significance stay with us in the BPrep program. Women who have a personal history of radiation to the chest before the age of 30 are also at elevated risk for breast cancer. Those women stay with us. Personal history of breast biopsy showing a high-risk lesion, which we'll talk a little bit more about this morning. And then women who have an elevated lifetime risk based on breast cancer risk prediction models, or those that have extremely dense breast tissue. So this is the group that is, we know, at elevated breast cancer risk, and this is our program is there to serve these women, again, to offer them opportunities to reduce their risk, as well as to provide good ongoing clinical care. So this is our BPrep team. It's a multidisciplinary team composed of surgeons, of medical oncologists, again, medical oncologists with an interest in risk and genetics. We have Mary Beth Hans, who I've highlighted here, who is co-director of the program with me, a senior PA, a senior NP, and a nurse. And I want to really highlight this bottom row of folks here. This is really our clinical staff. We couldn't do any of the good work we do without their support, helping us get the patients in and taking excellent care of our patients. So our program really is about prevention. We really do hope to make an impact on each individual that comes in, but also to make an impact on the overall trajectory of breast cancer in our communities. And so we started the program in 2017. This is just a snapshot from our forum in 2019. This is one of our first patients in our program, one of our first patients to participate in one of our clinical trials. She actually spoke at the forum in 2019, and her video is available on our website, a really powerful testimony to how our program impacted her and helped her. Excuse me. So a little plug here. We are, again, trying to do our best to help women understand their risk, but we still know that we do have disparities in our environment. So we know that Black women are disproportionately affected with more aggressive cancers, and Black women are more likely to die from their breast cancer. We have, again, a multidisciplinary team that includes a research team, and our team is studying the impact of societal stress on the immune system as a potential contributor to the disparities in outcome for Black women with breast cancer. Our team submitted a project to a mechanism called Bright Futures, and they were selected from over 20 projects to be as one of 3 finalists for this prize. Now it's essentially popularity contest. So now who wins the prize is based on how many votes the teams get. And so here's my selfish plug to ask each of you to go on to www.brightfuturesprize.org. And for our team, the team is listed shown there. And the team, we really, again, really want to learn more about how stress and the immune system leads to increased breast cancers, aggressive breast cancers in Black women, and increased rates of death. So I'll show this to you again at the end, but we appreciate your vote so we can take this really important work forward. So let's just start then with a little bit. So what is cancer? So cancer is essentially a group of diseases characterized by uncontrolled growth and spread of abnormal cells. And with respect to the breast, this little cartoon highlights here. So the normal milk duct is just lined by a single row of cells, all very uniform, same size, same shape. One of those cells goes bad for whatever reason and starts dividing. And then in the middle panel, we see those abnormal cells now filling the milk duct. And when those cells stay inside the duct, as shown there, that's the pre-invasive stage, or you'll hear the words carcinoma in situ, duct carcinoma in situ. So that's the earliest form of breast cancer. And when those cells break through the wall of the milk duct and get out into the fatty tissue of the breast, that's when we have invasive breast cancer. And so what does it mean to be at increased risk? Well, it simply means that your chance of developing breast cancer is higher than the average woman. And so in the cartoon here, we have 100 women, and the average risk is 1 in 8, or 12%. So the average risk woman has a 12% risk of developing breast cancer over her lifetime. We certainly know that there are a lot of risk factors for breast cancer, and we're going to touch on a lot of them today. Again, a very common one that you hear about in the press is inherited mutations, so germline predisposition to breast cancer. And we will have a genetics overview from Jill Stopfer today, one of our frequent speakers here in our BPREP program. So she'll be talking about genetics a little bit later this morning. We know that there are other risk factors, and these are what we call sort of reproductive risk factors. Your doctors ask you when you started your menses, if you've been through menopause, how many children you have, et cetera. And those factors are used in what we call our risk prediction models. We do use these models in our clinic, and they do give us a nice starting point to talk about risk. But the models are not perfect. There is some variability, and we know the models don't account for race or ethnicity, again, which I said is very important in what type of breast cancer women get. And the models all don't account for lifestyle factors, which we're learning more and more about how those impact risk. So these are the 3 sort of top lifestyle factors associated with breast cancer risk. So there's lots of evidence now about alcohol, obesity, and exercise. For women, drinking more than 1 drink per day is associated with an increased risk for breast cancer. Gaining weight when we go through menopause. So postmenopausal breast cancer risk is certainly linked to obesity. And then exercise. We know that women who regularly exercise have a reduced risk of breast cancer. And of course, the more you exercise, the more your risk is reduced. Obesity is a significant problem in our community, in our world. In the United States, it's estimated that over 40% of our population is obese. We know that over 1 in 3 adults struggle with obesity, and only about 1 in 4 adults meet the physical activity guidelines as set forth by the CDC and the American Cancer Society to help reduce risk. So we're going to hear this morning from Dr. Eliason about the role of diet in breast cancer prevention and survival. And I know this is going to be a really informative talk. Looking forward to that later this morning. And we're not going to talk specifically about exercise in this session, but I do want to highlight that we have had speakers on exercise in our previous forums, again, in our 2020 forum. And so you can find a really nice lecture online about exercise. But again, we do know that physical activity reduces breast cancer risk in both pre- and postmenopausal women. The mechanisms of how this exercise helps are various, and there's lots of continued work to understand how exercise reduces risk. But it is important to have regular exercise, at least 2 to 3 days per week of moderate to vigorous exercise, with about 150 minutes per week or of that moderate intensity exercise. And this can be both aerobic and resistance training. And so again, for more information, I point you to our website, our form from 2020. We will have an exercise demo, though. We'll let you get up and stretch your legs a little bit during the morning. Nancy Campbell, again, a frequent speaker, a frequent contributor here to our program, and she will show us some nice activities that we can do just to break up our day. So again, exercise consistently shown to reduce breast cancer risk, and standard recommendations for breast health should include consuming alcohol in moderation, maintaining a healthy BMI, and including moderate intensity exercise. So our program, we take very seriously the personalized aspect of our program. Our goal is to really match each individual's unique risk profile with realistic, practical, and acceptable lifestyle changes or interventions to help women reduce their risk. And of course, we like to provide the opportunity to participate in clinical studies as well, but we know that there's a lot that we can do outside of those clinical studies. So just a little bit more about some of the other risk factors then. We hear a lot about breast density. Breast density is how your breasts look on a mammogram. It's not how they feel, but it's how they look on a mammogram. And here I'm showing you 4 different images where you can see on the to your far left, that's a woman with fatty breasts, so that's not dense. And then all the way across to the right, you see we have increasing levels of density. And it's the far group on the right, the extremely dense breasts. This is the group that is associated with increased breast cancer risk compared to women with fatty breasts. But it's important to note that most patients fall into the middle, fall into the 2 or 3 category here in the middle, and there is no significantly elevated breast cancer risk if you fall into the categories 2 or 3. It's just if you fall into that category 4, which is about 10% of women. So what is that increased risk? Well, we talk a lot about relative risk, 3 to 5 times, but the relative risk is not really what you want to know. What you want to know is your absolute risk. And so for women with those extremely dense breasts, here we have those 100 women. And so about 15 to 20 of those 100 women will develop breast cancer due to their dense breastity, or their risk is increased due to breast density. And again, that's about a 15 to 20% absolute risk. We'll have a nice overview of breast imaging this morning by one of my colleagues at the Brigham, Dr. Cho. She'll talk to us about the different modalities and again, what those risk factors mean. High-risk breast lesions. As a surgeon, this is a group of lesions that I am interested in, and we see women again who come in with these lesions. There are about 1 million benign biopsies performed in the United States in a year. About 10% of those biopsies will demonstrate atypical hyperplasia. About 4% will demonstrate what we call lobular carcinoma in situ. And these are what we call the high-risk breast lesions. And so again, about 140,000 patients will be diagnosed with these lesions each year. We call them high risk for 2 reasons. Some of them, when diagnosed on a core biopsy, have a significant chance of actually being associated with cancer. And so we recommend surgical excision as a first step to make sure that there's not a cancer present. And this is most common with the lesion that we call atypical duct hyperplasia. We know when we take these patients to the operating room that up to 30% of them will actually have a breast cancer at that time. And so they are high risk because it's a core biopsy that may be upgraded to a diagnosis of cancer. Again, we're not going to specifically talk about these lesions this morning, but I will refer you back again to our form from last year, 2021. The video is online where we had a really nice talk from our pathologist, Beth Harrison, talking about these lesions and really describing them quite nicely. But once we're sure that a patient does not have breast cancer at the moment, we know that there's some of these lesions that do put women at increased risk for breast cancer in the future. And so again, the three most common lesions that confer breast high risk in the future are the atypical hyperplasias, atypical ductal and lobular hyperplasia, and lobular carcinoma in situ. And we know from very nice long-term follow-up studies that women with the atypical hyperplasias develop breast cancer at a rate of about 1% per year, and women with lobular carcinoma in situ, it's about double that, about 2% per year. And so again, this is a group that we are particularly interested in understanding what confers this risk and how can we impact risk in these groups. So again, translating that into for an individual, what is the risk? So women with ADH or ALH, again, about a 15 to 20% lifetime risk of getting breast cancer. For women with lobular carcinoma in situ, again, that's up to about a 20 to 25% risk, of course, depending on the age at diagnosis. The models, it's important to know that the models don't really perform well in women with these high-risk lesions. So we don't really promote the models. We know that the Gale model underestimates risk for women with atypia, and the Tyrer-Cuzick model really significantly overestimates risk for women with these lesions. And so I just put that out there in case you are looking at these models or you receive a score from one of these models. If you have a high-risk lesion, they're not really very accurate. We do know that other factors can contribute to that risk. So women with LCIS and dense breasts have a higher risk of developing breast cancer than women with LCIS and fatty breasts. And that's demonstrated here in this nice work done by my colleague, Christina Minami, who is one of our breast surgeons. But more importantly, highlighted here is the impact of chemoprevention. So we know that the medications really significantly reduce breast cancer risk. You can see it reduces breast cancer risk by about 50%. That's what the hazard of 0.49 means. So these medicines are particularly effective. And here's just another way of illustrating that. This is a large group of women being in follow-up from Sloan Kettering when I used to be there. And you can see that the women who took chemoprevention in the red line are developing cancer at much lower rates than the women who did not take chemoprevention in the blue line. And we're going to hear again about these medicines this morning from Dr. Bishkovsky, one of our medical oncologists that works in the BPREP program with us. So there is a large population at risk for breast cancer. About 10 million women in the United States between the ages of 35 and 79 are eligible for chemoprevention based on elevated risk. And this really represents about 15% of the population. And it's really, the onus is on us, again, to provide this education and also to provide options that are tolerable for women to reduce risk.